Good evening, everyone. Thank you so much for being with me in this session. It's a free webinar. I would like to discuss in this webinar what are the news in pelvic floor diseases, urge incontinence, stress urinary incontinence, and other problems in postpartum period as well as during pregnancy. It is the famous TOG article released 2022, and we need to know more about the news in these topics as much as we can to be prepared well for any question in part 2 MRCOG examination. So I know most of you may be at the time of iftar now, or you are still fasting like me. So the ATPs in your brain are very limited. So I will be shortcutted for all knowledge, and I will be targeted and focused regarding the most important things to be remembered for exam preparation. So it's obvious that the delivery, pregnancy, and labor delivery are the biggest and most important stress factors on female pelvic diaphragm. I mean the pelvic floor muscles, which will reflect later on the pelvic organ prolapse as well. Patients may complain either from urinary or fecal incontinence, plus or minus presence of pelvic organ prolapse. In pregnancy, we notice that there are some physiological changes happen during pregnancy and start to decline during puerperium. Okay, these changes are dilatation, incontinence, retention. The dilatation happened in the different urinary tract organs like ureters, bladder muscle relaxation, and then the infections will develop due to the stasis of the urine. The infections will lead to stretching of the bladder and weakness of the muscle. Then the bladder tone will be decreased, urethral pressure will be increased, edema of the wall will happen normally. All of these factors leads to either incontinence or less commonly urine retention. Okay. The most common complaint in Europe and UK through urinary symptoms in pregnancy and even outside pregnancy, the stress urinary incontinence. Around 10 to 20% of women suffering from incontinence in non-pregnancy situation. 50% of them are stress urinary incontinence. But this prevalence increasing during pregnancy to up to 75% of women will experience at least once attack of leakage of urine, stress urinary incontinence during pregnancy. The vaginal route delivery also is associated with around 8% more risk of persistent SUI in postpartum period in comparison to a woman delivered by cesarean section. What happened exactly in stress urinary incontinence? The problem was a descent of the bladder neck below its normal position due to weakness of pelvic floor muscles and supporters. This descent leads to loss of the valvular action of the bladder neck. So simply, when increased intra-abdominal pressure or intravesical pressure simultaneously, There is no valvular action by the bladder neck. So few drops of urine may escape easily from the woman. And this is what is called stress urinary incontinence. The problem in SUI is essentially anatomical, is essentially pathological. It's not a functional problem. It's an anatomical problem. So the correction or the management should be essentially surgical correction. Keep it in your mind. You know, if we have an anatomical problem or an obvious pathology, we have to treat it by surgery. This is the best option. If we have a functional problem, we have to manage it by medical options. So functional problems will be managed medically, essentially medically. And the organic problems, anatomical problems, should be managed surgically. This is very logical. So when I ask you how to manage stress urinary incontinence, you should think about something to strengthen the pelvic floor muscles and surgical intervention to elevate the bladder neck descent. I'm right? This is the most appropriate options for the correction of SUI. But in pregnancy and postpartum women, somehow it's different. It's different. Why? Because, sorry, I will be back again. Sorry. Yeah. In pregnant women, the conservative management is the ideal option. The woman will be just only offered pelvic floor muscle training. She will never be offering any surgical interventions in pregnancy, and even postpartum, if she's still not completing her family, if she's still looking for more pregnancies, it's not advisable at all to offer her any surgical intervention because the results will not be satisfying later on. So the fertility wishes is a critical point in evaluation of the best way to manage SUI. Okay, so the pelvic floor muscle training prevents and decreases the severity of SUI in pregnancy by increasing the strength of pelvic floor muscles. The ideal procedure should be offered to a woman to correct the SUI according to the NICE guidelines update 2021, Burch-Kolpo suspension, because other procedures are stopped, suspended, not recommended anymore, like tape insertion, TVT, or TOT. In this scenario, the Burch-Kolpo suspension, if this is the bladder in center part, the vagina is anteriorly here, okay? So I will separate the vagina from the bladder, and then the bladder, the vagina will be taken by 3 or 2 sutures on both sides to be suspended to the pectineal line of inguinal ligament bilaterally. Okay, the pectineal or Cooper's ligaments, pectineal ligaments, a part of inguinal ligament laterally, to elevate and pull the vagina upwards a little bit. When you pull the vagina upwards, the bladder neck will be pulled up as well as the part of the urethral course. So it will be more straightening. This is the Burch-Kolpo suspension, the golden procedure to treat the SUI. Okay, so imagine that I offer this procedure to a woman and then she get pregnant again. and delivered vaginally, for example. All of this work will be damaged completely. Other procedures like TVT, TOT, or the urethral bulking agent injections like Palcamade. The TVT, TOT are not used anymore in part 2 examination, so you should forget about them. The Palcamade injection is an alternative treatment, temporary treatment, may be used in pregnancy, in postpartum woman who is still looking for pregnancies more and more. So I can just inject it to solve the problem temporarily. So it's a very good option to a woman looking for further pregnancies. And the third line will be the medical treatment duloxetine. So to summarize, in pregnancy and postpartum women, no interventions recommended. Pelvic floor muscle training is the ideal option. If the woman not improved with pelvic floor muscle training and she is still complaining, but she is not completed her family yet, offer her urethral bulking agent injection as a temporary option until she's completing her family, and then you can offer her the colpo suspension, the Birch colpo suspension. And B, please don't use TVT, TOT, or duloxetine in the management of any SUI woman. What about the second problem, the overactive bladder? The overactive bladder is a case which the bladder muscle, or the detrusor muscle, is hypersensitive to any distension. So the women with overactive bladder, they are characterized by symptoms of urgency and frequency. Urgency is the most common symptom. Frequency, plus or minus, nocturia. The nocturial attacks may be present or not. Up to 40% of pregnant women experience micturition frequency during pregnancy. It's fine. Yeah, it's okay. No problems. But urgency nocturia is not common. Frequency is common due to a pressure of the enlarged uterus on the bladder. Unlike the SUI, there is no association between parity and mode of delivery and overactive bladder, because the problem in overactive bladder is not an anatomical problem, it's functional problem. The detrusor muscle is becoming insane. The prevalence of all lower urinary tract symptoms reduces 6 weeks after childbirth. So the TOG article advised us as there should be no evaluation for any lower urinary tract symptoms like urgency, frequency, burning micturition, like pain down below, like SUI symptoms, up to 6 weeks postpartum, because the symptoms will be declined spontaneously. How to manage the overactive bladder? Most of you knows that the overactive bladder is functional problem. So the management should be medically essential. Primarily, I have to ask the woman to stop any caffeinated drinks, stop taking too much fluids, do some pelvic muscle training, do bladder retraining with a nurse to, like doing desensitization to the bladder muscle. If all of these staff failed to manage, the second option will be the medical treatment, as this is the ideal option to be offered to this patient. A group of medications called anticholinergic treatments or antimuscarinic treatments specifically oxybutynin, teltirodine, or sulfanicin, can be offered to control the symptoms. They are considered safe during pregnancy and breastfeeding. So can be used either in pregnant women and or in postpartum period. Sometimes, and this is critically important in the exam, sometimes the woman in the postpartum breastfeeding period, the prolactin high levels antagonize the estrogen effect. So the woman may suffer from urinary symptoms because of mucosal urethral atrophy and vaginal atrophy due to relative decrease of estrogen effect. So how can we manage this? Low dose local vaginal estrogen creams and gel should be offered to those women parallelly to the anti-muscarinic treatments to control the symptoms. Please remember that the local vaginal estrogen cream is not only offered to menopausal women for dyspareunia or something like this. No, it could be used with young age women in cases of breastfeeding, because those patients are suffering from dryness down below. If the medical options failed, so we think about surgical interventions like Botox injection, for example, to control the involuntary muscle contractions. But Botox may be used in pregnancy. It's not commonly offered, and it's associated with increasing risk of urinary retention. So in exam, don't offer it. As well as don't offer sacral nerve modulation or sacral nerve stimulation. Should not be offered during pregnancy, okay? Just to summarize, as usual, most of symptoms will be reduced after 6 weeks after birth, childbirth. So don't start any intervention before 6 weeks postpartum. The incidence of OEB is higher at 6 weeks postpartum in those women who delivered vaginally rather than via cesarean section. And the SUI symptoms are more common with vaginal birth compared to cesarean section. The conclusion is cesarean section is associated with decreased rates of postpartum SUI as well as postpartum OAB. Cesarean section is not that bad, I think. The third problem that may happen, you may have a scenario like this in pregnancy or postpartum, is the POP, the pelvic organ prolapse. The pregnancy and delivery are major risk factors for such prolapse. The prevalence in UK is maybe up to 10% of women have some kind of prolapse, either vaginal anterior wall, vaginal posterior wall, vault prolapse after hysterectomy, or the uterine prolapse itself. The prolapse should be classified like this. The normal anatomy: cystocele, the anterior wall prolapse inside the vagina; rectocele, the posterior wall prolapse inside by the rectum inside the vagina; uterine prolapse, the whole uterus itself is outside or down below; and the vault after hysterectomy, total hysterectomy, may descend as well. What are the important risk factors for developing BOB later in life? Prolonged first and second stage of labor, third and fourth degree prenatal tears, which is not corrected well, huge size babies delivered vaginally, and of course, traumatic instrumental delivery. The management, it depends on It depends on the complaint and the fertility wishes. So, for example, if the woman completed her family with uterine prolapse, I will go for vaginal hysterectomy. It's very logic. But if it's the woman is still looking for another baby or to complete her family, and she's still young, I will change my plan to support and fix the uterus in place. So I will go for hysteropexy. Hysteropexy. So the fertility wishes are critical point to evaluate the management of POP. But the lifestyle modifications, including loss of weight, exercise, pelvic floor muscle training mainly, quit smoking, treat any causes like chronic cough causes, chronic constipation causes, to prevent intra-abdominal raising pressure regularly. All of these stuff are really helpful. Sometimes vaginal pessaries can be used as an temporary option to elevate and control the prolapse, especially also if the woman is looking for another baby, for example. Surgical intervention is not recommended before a woman has completed her family. If the woman had any fixation surgery, sacral or sacrospinous hysteropexy with vaginal mesh should be offered. And then the woman should be delivered by cesarean section. Forget about Manchester procedure, forget about Fothergill procedure. They are not in your curriculum anymore. So what you need to know in POP management, just it depends on the fertility wishes. If the woman has no further plans with her family and the uterus is descended down below, vaginal hysterectomy is the ideal option. Okay. One of the most common topics that may affect the pregnant lady or in postpartum women as well, the urinary tract infections. Symptoms are the same as in non-pregnant women, like burning micturition, which is a leading word. It could be also presented by dysuria and some urgency and frequency. The incidence of UTI during pregnancy, according to the TOG, is approximately 8%. 8%. One of the most common problems with pregnant women. Please notice that there is a big difference between urinary tract infection and pyelonephritis. Pyelonephritis is a severe, serious kidney infection developed after unrecognized, untreated urinary tract infection. So the 2% of pyelonephritis are developed on top of the 8% risk of UTI untreated, which is developed on top of 25% risk of asymptomatic bacteriuria. So they are like a step, a group of steps. You imagine that, a group of steps. The first essential problem is asymptomatic bacteria. The woman has a bacteria, no symptoms, not discovered in 25% of pregnant women. After a while, UTI developed, preterm labor may happen, B-prom may happen. Why? Because untreated asymptomatic bacteria. If the UTI also is not treated, it will develop into ascending infection, kidney infection, pyelonephritis, which may lead to critical serious renal failure. Asymptomatic bacteria is the most important risk factor. Yes. UTI during pregnancy can also result in chorioamnionitis, small for gestational age, beside preterm labor, premature rupture of membranes, and stillbirth babies. The first line investigation, it's very easy. You have to go for a urine dipstick analysis. It will catch if there is any bacteria infection or nitrates as well. The nitrates positive in complete urine picture analysis, it reflects the presence of bacteria, as the nitrates are the end metabolic product. So even metabolic product of the bacterial cycle. So even if the analysis shows no bacteria infection, but there is nitrate positive finding, you should think about doing culture and sensitivity. So after urine analysis or urine dipstick, you have to ask for culture and sensitivity to confirm the diagnosis. However, 80% of UTIs are caused by the most common pathogen, E. coli. E. coli. But the TOG article not only discussed the UTI, they were really concerned, and this is extremely important for your exam, regarding the recurrent UTI. The recurrent UTI means 3 or more episodes of UTI in the past 12 months, or 2 or more episodes in the last 6 months. So this is the ideal definition. So any woman with more number of attacks or episodes of UTI annually or every half an hour year should be diagnosed as recurrent UTI. The problem here is not just an infection. The problem, maybe the woman has no clinical infection, but she's carrying the microbiome, the origin of the infection later on. It's common problem in postpartum women and post-menopausal women. Main risk factors for recurrent UTI are high parity, frequency of sexual intercourse, low socioeconomic class, any urinary tract problems like renal stones, renal anomalies sometimes, and the maternal history of UTI or first UTI attack at younger age than 15 years old. How can we treat the recurrent UTI? Please remember that in pregnancy, nitrofurantoin is ideal option except in last trimester. So I can use nitrofurantoin as the best option in first and second trimester. Okay, but I will choose trimethoprim in the third trimester and avoid it in the first trimester and second trimester. So first and second, nitrofurantoin. Third trimester, trimethoprim. I'm always saying that, look at this. I'm always saying trimethoprim, it will be TT with third trimester. Okay, third trimester, TT. Okay. Amoxicillin or cefalexin, cephalosporin may be an alternative, but they are not the primary option or the ideal option. Now look at this. This is the key and the most important answer right now in the exam. The lactoferrin, ascorbic acid, D-mannose triad should be used either in pregnancy or postpartum period for patients with RUTI. Okay, so the complementary or additional treatment are evidence-based, yes. They are accepted, yes. Recommended, yes. And they are the triad of lactoferrin, ascorbic acid, vitamin C, and D minerals. The other point for single breast answer should be like this. For those women with history of recurrent UTI and they are pregnant, fortnightly, I mean every 2 weeks, urine testing should be offered until 36 weeks of gestation and then weekly until delivery. Why? We are looking for asymptomatic bacteria at any point, so we need to treat it before developing into a serious infection. So with RUTI history, women should be offered once every 2 weeks testing until 36 weeks, and then urine analysis weekly until delivery. Is it clear, everyone? Keep these points in your mind. The final problem we will discuss today is urine retention. Urine retention is not an uncommon problem. It's common condition, especially in postpartum period. And I remember clearly in the February and November exams in part 3, many stations, all days, always there is a station about urinary retention post-vaginal delivery, instrumental delivery, urinary retention after emergency cesarean section. So it's extremely important and common scenario. In postpartum urinary retention, it may happen around 25% of women. Wow, huge number. It could be offered like inability to void spontaneously within 6 hours, and this is the definition of urine retention, the inability of the woman to void spontaneously within 6 hours of vaginal delivery or removal of the catheter, or it could be covered, PUR, post-void residual volume of greater than or equal 150 milli after spontaneous micturition or evacuation. What are the risk factors for possible urine retention? The risk factors are simply epidural analgesia. This is the most important question you have to ask the patient in history taking or in single breast answers to think about. Patients with epidural analgesia, if you revise the epidural, you will discover that epidural is responsible for 2 things. Prolonged second stage, yes, I agree, and increasing risk of postpartum urine retention. So PP, prolonged second stage, postpartum urine retention. This is the epidural analgesia. An instrumental delivery, trauma to the pelvic floor, 3rd and 4th degree perineal tears, extended episiotomy, physiological changes sometimes, such as increased progesterone levels, as we said before. The progesterone will lead to dilatation and urine stasis. Okay? So all of these are risk factors. How can I manage? It's very easy. Don't look here. Just keep remembering this beautiful diagram. This beautiful diagram, if the woman is unable to void urine after 6 hours of removal of catheter or spontaneous vaginal delivery, I need to insert a catheter. Yes, I need to do that. Why? Because I need to check how much urine inside. You know, this diagram is critically important because it's new. It changed the previous one, replaced the previous scheme. So I suggest that most of questions will come in this diagram this time. I will insert the catheter. If I find it like less than 150 milli inside the post-residual volume, is less than 150, it's okay because it's accepted postnatal. But if I find it like from 150 to 250 milli, some problems may happen. So I will give another choice for spontaneous void at 6 hours. If the woman can void, it's okay. I will remove the catheter. If the woman after 6 hours cannot void, I will keep the catheter inside her. And if the volume is from 250 to 700 milli, I will automatically insert the catheter and keep it for 24 hours and then retry evacuation after withdrawal of the catheter. TWOC means trial withdrawal of catheter. Okay. If the amount is more than 700, something wrong with the nerves and sensation of the bladder. So I will let patient go home with a catheter insertion for 2 weeks. And then I will remove the catheter after this for re-evaluation. This is the management. This is the management. Got my point, everyone? This is how can you manage urine retention after a vaginal birth or a traumatic cesarean section. We did it. We discussed successfully all points related to the pelvic floor muscle problems in pregnancy and purpurium, and we revised what are the differences in management between women in pregnancy and outside pregnancy, in purpurium and in outside purpurium. How can we manage the problems here and there? Thank you so much for being with us, mid-exam expert, and me, Mohammad Hassan. I was really happy to share this session with all of you. And thank you despite the time and the effort and Siyam, Ramadan, everything. I was really happy and I appreciate this. PopQ classification, Breya, is not important. 100% yes. PopQ quantification, the diagram is always presented in the exam, I mean in part 3 exam, but the details will be in front of you and no need to remember the points of PopQ classification. It's not your job. Trust me. Ramadan Kareem, everyone, and enjoy the session again. You can hear it again. Just write out the points we discussed together to be ready and keep them in your mind, clear in your mind. So when you are going to revise before the exam, you will find it very easy. Always try to write everything by yourself. Take the shots, the points, the focus things, write them outside, and then revise from what you wrote. You will find it very easy later on. Have a nice day. Enjoy your time. And thank you so much. See you soon. Bye-bye.